So we're running out of time, so I'm just going to basically try to share with you our experience in our institution, basically, on the management of critical ischemia. The amputation for us in the U.S. Is as much of a problem as it is in the rest of the world. 82% of all the U.S. amputations are due to vascular disease, becoming a serious problem for us. Less than 50% of those in which we do an amputation are able to achieve full mobility. And whether it's below or above the knee, the certainty is that it's suboptimal. In addition to that, one of the things that often gets overlooked is the fact that the morbid mortality of these patients as a whole is quite significant. So one of the speakers before said that we have to treat the whole and not the whole, and I think it is very true, because ultimately revascularizing the limb is important, but the morbid mortality that these patients bring to the table due to their cardiovascular disease is quite significant. At the point that at 3 years, less than 50% of those patients that present with critical ischemia will not be alive. In addition to that, for us in the US, it's extremely expensive the management of these patients. Most of the patients do not get discharged home. In fact, they go to another facility after the hospitalization, and the annual cost of that is about $100,000. In addition to that, we usually have to modify their home environment to be able to send them back. The truth is that on a yearly basis, we spend anywhere between $10 to $20 billion alone in the management of patients with critical ischemia, becoming this a paramount problem for us and a great center of our attention. When you look at amputations as a marker of disease, and we contrast that with myocardial infarction and stroke and cardiovascular death, we see that those that had an amputation versus those that didn't, the outcomes are very significant. So with all this background, we started to create what we call a multidisciplinary team at our institution. And we stopped the war in the US. Unlike other parts of the world, cardiology wasn't a major player in the management of patients with critical ischemia or the treatment of endovascular disease. And as we started to grow into this field, there was a turf battle between all the specialties, vascular surgery, IR, and cardiology. And we all were trying to fight as to who was going to treat the patients. And in one of those meetings, somebody said, even if each one of us treat all the patients, we still would need more doctors. We still need more specialists to be able to do this. And instead of taking a separate approach, we basically tried to come together. And what we did is, we did two basic things. Number one, we created a multidisciplinary clinic where patients with critical ischemia are seen and evaluated in conjunction by IR, cardiology, and vascular surgery. And we look at the patient from their disease state, and we treat them based on what they got as opposed to our personal preferences. Whether I'm a cardiologist, an IR, or a vascular surgeon plays no role in the decision-making process. We look at films, we look at patients' comorbidities, and based on that, we make a decision. So that's one thing that we implemented. And the second is that we divided our algorithms of therapy based on areas of interest and or professional development. Within our group, there were some of us that were specifically interested in critical ischemia, and that allowed us to develop algorithms that resulted in the following. About 10 years ago, the rate of amputation in our institution was about 500 amputations per year. Keep in mind that it's the fourth largest hospital system in the United States, our hospital, with about 2,800 beds. And with the implementation of this multidisciplinary clinic and these different algorithms and try to triage the patients according to who was better at certain things versus others, we started to notice a significant decrease in the rate of amputation. 10 years later, our rate of amputation is about 75 cases per year. And many of it stems from the point that the patient are seen as a whole human body that not only has a wound that doesn't heal, but a bunch of other aspects that need to be taken into account by different specialties, cardiologists, surgery, IR, podiatrists. So becoming a very important paradigm to be able to show to the rest of the world and other group of doctors that are still struggling with who should be treated these patients, how should they be treated, and focus more in the issue of the fact that it's a multidisciplinary approach and not so much a business where either one specialty or the other is losing control of. In the interest of time, I'm just going to stop here And if there are questions or concerns, I am happy to give you more specifics about our program.
Yeah, actually, I have a question. I mean, just briefly describe how do you guys do it in Yale? I mean, how does it work?
Yeah, so basically, a patient comes into our clinic. It's a setup where it's a stations. So a patient comes with critical limb ischemia, gets interviewed by an endovascular specialist, as well as a surgical specialist. In other words, two of us are in the clinic seeing the patient together. Depending on the patient's comorbidities and/or the anatomic findings and the clinical presentation, we decide endovascular versus surgical. Based on that, the patient just goes to a social worker that coordinates the patient's living conditions and environment where they're going to go back after the intervention. In addition to that, they go to the next station where they see podiatrists who help us with the wound care and the management of the foot. At the end of the visit, which usually takes about 40 to 45 minutes, the patient usually sees about 4 to 6 providers. And the patient leaves the appointment with a date for a procedure, whether it's surgical and/or endovascular, with a plan for secondary management from the cardiovascular point of view, meaning what are we going to do to the coronaries, do they have carotid disease or anything else, with a plan with the social worker and how they're going to support it to be able to go back to their environment, and a plan with podiatry in terms of what debridement is going to take place, when, how. So every patient is submitted to this process, and that's how we were able to decrease that. In addition to that, one of the things that is happening is because the surgeons back in the days were not necessarily doing much endovascular approach. Many of those patients were amputated even without an angiogram. So we basically created a policy that anyone that has critical limb ischemia must have some form of vascular evaluation before an amputation is performed, whether it's invasive or non-invasive.
So it's a written policy in your hospital?
Yeah.
Okay, that's it. So we have a lot of problem, you see, in our culture. You know, first they don't come to doctors, they go to herbal medicine, honey, and this, and cautery. And when they reach the doctors, they didn't have to go really to the vascular specialists. They go to a general surgeon or to an orthopedic surgeon, or, you know, and the amputation is very high. And the other problem, we don't have foot specialists who you could do the best angioplasty with recanalization, and he will still lose his foot because there's nobody to take care of the wound after that. So these are the challenges. And in the society, we're trying now to develop an amputation prevention program. And we would love to, you know, work with you and Dr. Schmidt and I know anybody who can help us also in Turkey, the experience of how can we implement these programs and involve everybody, vascular surgery, cardiology, radiologists, whoever does this with the wound care specialist, so that we have you know, more better income. A lot of amputation. In Riyadh alone, the capital of Saudi Arabia, which is a rich country, we have 90 amputations per month of the diabetic foot, which is very high. So imagine other countries. So this is a major problem.
Right. Andrew, I don't know if you have any comments about that, how you guys do it in Germany, and what you find effective or not.
Yeah, well, it's the same as you do. I mean, and you say it's the multidisciplinary approach to do the same. So it takes time and a lot of disciplines.
Yeah. And patient awareness is critical, because if the patient doesn't realize that ulcer that they have is a problem, it doesn't matter how good your hospital, your doctors are. If the patient doesn't come into the hospital, there's nothing we can do about it. So patient awareness, and that was something that we invested a lot in our health system to get the patients into the door.
Dr. Shaqaw from Masr has...
Yes, actually the problem of losing the diabetic foot in our country was great until we created a special protocol for etiological detection of all the causes of this disease and the loss of the limb due to unhealing ulcer or hidden pathology. This protocol is color-coded, and if you follow the protocol, you can never miss an etiological factor and the way to do the proper management of this etiological factor. The limb saving after this protocol and moving in it reached more than 70% of the cases that was supposed to be for amputation, whether minor or major, above or below the knee.
Okay, we
This
need to-
protocol, I can send it to you to the email today. You can put it over the server if anybody want to.
Thank you
just
very much. Yeah,
download
thank you very
it.
much. So the message here is develop a multidisciplinary program, develop your CTO techniques to improve your success, and consider drug-eluting technology. Thank you very much. Thank you.